Hello, everyone, and welcome back to the RPE podcast, where we aim to bridge the gap between rehab and performance. I'm your host, Connor, and today I am joined by Steve. How are you, mate?
Yeah, mate. No, good. It's as I said, it's been a while, so we're all a bit rusty, and you probably this is it seems like questions without notice this morning. So I'm
Mm.
going to do my best politician of answering, but not actually answering.
No, these are I reckon you'll get them all. I think it's probably a relatively easy type thing we're
Oh,
going to go
don't say
through.
that now.
I'm going to hype it
Now
up
I'm
to be
cooked.
super easy because today we're going to be continuing our bone loading series, and we haven't talked about fractures, and it would not be a bone loading series if we didn't discuss fractures quickly. So, we're going to try and make fractures a little less boring than potentially what they could be by quizzing Steve on what he knows about fractures.
Oh God,
How much, how
not
confident do
what?
you feel with this?
Oh, mate, not very. But you just gotta. All you can do is the best. So let's have a crack.
Well,
Get it? Have a crack. Fine. Fracture.
before we jump
Have a
in,
crack.
couple of little announcements to make. Uh, Thanks to everyone who comments on in through whatever they comment on, whether it's on YouTube, whether it's in Spotify. But shout out this week goes to Debbie Hughes, commented on our last example scenario with our bone loading. So thanks, Debbie, for tuning in. Also, all of our episodes are out on YouTube now, so they're all edited and you can see our faces if you want to. I think probably and the fins, up the fins, get your fin up. For those who are not interested in rugby league, that is Steve's favorite team. So
My local team.
you can see some fins merch on the podcast as well. And last announcement is Steve has kind of moved over to the dark side and just started something completely different, just doing his own thing with the very informative and very good talking Dave Renfrew. So did you want to
Mate,
just
it's only because you're bloody other side of the world, impossible to get hold of. Have
no,
to
it's
talk to someone.
they explore. Yeah, do you want to give us a little bit of a plug on your new potty?
Yeah, yeah. Grey Matters podcast, and it's just really kind of going into a lot of the more like deeper, broader topics in physiotherapy and strength and conditioning, and in like just dealing with people. A lot less like of the pragmatic and that type of stuff, and looking at like the systems and the psychology that underlies the decisions that we make and all that type of stuff. So yeah, it's interesting because Dave and I will be starting a course in critical thinking that we're going to be running, and so these are all going to be resources that are going to be done with that. So yeah, we're going to do a course for kind of newer clinicians as well as those that want to get a bit deeper into kind of critical thinking skills. So and research appraisal. So yeah, this is all just part of that.
Fantastic. Yeah, I listened to the first 6 episodes. I think there is, isn't there, at the minute?
Yep,
First
with
six
number
episodes.
4 missing.
Oh, really? And yeah, it is actually. Anyway, besides the point, yeah, no, it's been really interested to hear some more like philosophical and socio-political type chat around our profession. So if I would probably recommend any coach, allied health professional to go and check that out after they've finished listening to this. But let's crack in
This is more
today.
important.
Today we are talking about continuing the bone loading series, talking about fractures. So, Steve, first question. Types of
Oh,
bone.
geez.
Two types of bone, two major types of bone. What categories do
Do
they fit
you,
under?
Are we going to go like the like scientific, like the, you know, or the more like layman's name of like having your spongy bone and kind of your hard bone, or are you going to go
There you are.
like
Well,
your
you're halfway.
like
You've got
more
half the
cortic,
question, half points. Give me the scientific
the
as well.
scientific?
Yeah.
Oh, mate, then you got the more trabecular type,
Yep.
and then the other one is more cortical.
Correct.
Correct?
Correct.
Nice.
So you got
Yes.
cortical, or sometimes trabecular is also called cancellous.
Yeah.
Yeah.
Because it looks like sort of
So
kind of holes in it everywhere.
which one's which, mate?
The inside one is your trabecular or cancellous. So that can be like, area in which it isn't even like a lot of our immune cells are like made there and then like trained in the pancreas. So they're like made in that kind of trabecular bone, and then they're kind of sent to the pancreas and trained in the pancreas, and then they go off into the rest of the, yeah. So that's like the inside kind of bit. It's a lot more making up of the matrix of its ability to kind of bend and all that type of stuff and be a little bit more pliable, whereas then the outside kind of layer is a lot more of that kind of hard, kind of impact resistant part of the bone. I can't remember which one is more metabolically active. I would suggest it's probably the inside area, but I can't actually remember that bit. We did learn that at some stage, but
Yeah. I think it
yeah.
is the trabecular. Don't quote me on that. I'm not 100%, but I think it is. I think you're right with that one. It's the spongy type
Yep.
stuff. And that's not going to be super important for the rest of the questions today, but when we do eventually talk about bone stress injuries, that one will come into play there. So,
Yep.
next question. Fracture. What is a fracture?
Oof, fracture. Oh, I don't know, mate. That's a interesting one. I would just define it, I guess, as some sort of discontinuity in the cell kind of structure, mostly in the I just said them before. The heart,
All right.
not the cancellous, but the
Yeah, yeah.
what did I just call it before? How did I lose my names?
Look, you're three
But
quarters of the way there, so I'll give you three quarters of a point. So a fracture
yeah.
is defined as any breach in the continuity of the cortex of the
Oh,
bone. So you're
how about
pretty
that?
good. Pretty good.
Is it continuity? There you go.
So especially this is especially important if you ever work in the UK or if you're from the UK listening in. A lot of people will say that a fracture is not a break. Like over here, a lot of people perceive a fracture to be not as bad as a break, but they are indeed the same thing. People don't always need to be corrected on that, but sometimes it is important to correct them if they're kind of undermining the severity of the injury. So they're like, oh, it's just a fracture, like just a little crack, versus like
Mhm.
you've got to tell them, yeah, okay, it is actually still a break. So
Yep.
just an
Yep.
important little
And I guess it's
tidbit there.
just then, and people probably colloquially would associate like a break with like compound fractures or like comminuted, something that's kind of where,
Smashed.
yeah, and it's requiring like something to kind of realign the ends to be able to heal, or the ends are further apart that like the healing is going to take a lot longer. Whereas a fracture, people probably see as like, when you have like a little uh, like micro break in like a porcelain plate or a cup or something, and you can see that little line. That's probably what people are more thinking kind of as a fracture. And so, yeah, like colloquially, they're probably different, but they are the same thing.
All right, next question. How many
Oof.
stages are there in bone healing?
You got the soft cut. So first of all, comes in and the inflammatory response, and with that, then you got your soft callus kind of formation occurring. I can't remember if that's like stage 2 or stage 1, whatever you. I'd say inflammatory stage is stage 1. Then like you got a soft callus, which is kind of your stage 2, which kind of up to about that, or I don't know, 2 weeks, 3 weeks, and then after that, you're going to have like a harder callus forming where it's starting to lay down a lot of that, because first of all is like the fibrin and everything. So that soft callus is basically just trying to, I think of it almost analogous to skin. And like when you got that first like bit of a scab kind of forming, that's kind of that soft callus, but it can like pull apart really easy. Same thing with the bone, like it does that, and that's a really great time for it to heal, a great time for it to get just tiniest little bits of the right kind of whatever movement. It might be no movement at all, or it might be but just the right kind of mechanotransduction. And then after that, you get the harder callus forming, where that big kind of fibrin cap, and then all the calcium kind of bridging going across it. And then after that, it starts to, so that's 1, 2, 3. Fourth stage is when it's going to start to like remodel and like break down that kind of hard callus calcium cap. I can't remember what that stage is called, but that's
Right.
kind of how I remember it. And then it continues to like remodel for the rest of, bone is always
Forever.
remodeling, right? But yeah.
So you nailed it.
Depending on
First,
the forces put on it.
4 steps, nailed it. First one, hematoma formation. So you get like a bleed essentially, and then that's when
Yep.
it clots and makes the scab. 2, granulation tissue or soft callus. So that's where your fibrin and your cartilage get kind of laid down. And then as they mature over the next few weeks, you get bony callus formation, as you said, and then stage 4, bone remodeling. Don't think really we
Oh,
need to go into too much more depth than that. I don't think you need to kind of know anything extra in depth with that.
I
Um,
I actually think though for clinicians, especially around like say there's times that you are managing something that so say classic example, lateral ankle sprain, and you're considering they were positive on auto ankle
mm,
rules of like a little bit of say like tendon to palpate on that the posterior part of the medial mal or something like that, the posterior distal part of the medial mal, and you're going, or the lateral malleolus there. And then you're going, oh, like, okay, yeah, and they were a little bit sort of walk, and you've given them that informed, like, okay, this is what we'd do, like, and they have a timeline on it. They got like some sort of timeline. It's not just, oh, I have forever to just do whatever it is that we want. Well, then knowing these phases and going, okay, cool. Well, if we're gonna boot you, and we can manage it kind of like just a really bad ankle sprain, but with just a little bit more if you're not wanting to go down the path of, yep, no matter what, we're going to x-ray, then no matter what, we're going to wait till it kind of is fully healed and re-x-ray and that type of stuff again. Like, again, informed consent, usually you'd say this is the best management, but if they're wanting to try to get back a little bit quicker, well, then knowing these phases of going, okay, soft callus formation, we don't really want to be before that's happened, no real movement in this thing, because otherwise you're just not going to get this any union happening, in which case the best that you can hope for is that your body just like eats away whatever little bit has been kind of fractured off.
mhm.
To then go, okay, cool, once we got that hard callus, okay, now we can probably start to be putting a bit more weight on it in the boot and doing a bit more like exercises with it in the boot, just to be getting some mechanotransduction into it, but not stressing it like through strain, like
Straining it.
through an actual bending
Mhm.
force kind of thing. So I think that's where these can be really important, is to be like, if there's times with, and there's quite often with athletes with this, where they're going, cool, bad lateral ankle sprain, but they have a time frame they kind of got to get back to, and it's either their options are either wait for full bone healing, which is going to take a decent amount of time, try to go get as functional as you can with, let's see if the bone can heal, and
Mhm.
then C is just treat it like only a lateral
Ankle.
ankle ligament, and then like know that you're very likely, if there was a little fracture there, and maybe you scanned it or not, most you're supposed to scan with the auto ankle, but if there's a fracture, you're basically saying, I didn't really care about that, and I'm going to allow the body to just do whatever it was going to do with it
Great.
and
And
take the risks.
great. Yeah, I agree with that. But the first thing you mentioned right from the start, which coincidentally is the next question, Ottawa
Oh,
ankle rules. What are the Ottawa ankle rules?
So you got your malleoli. So on each side, it's the distal distal back, so back half of the
Posterior.
medial one. Yep, posterior. I'm like a physio and educator, don't know me bloody words. Staying on the medial side, we got like navicular. Going over to lateral from there, you got the base of the fifth, metatarsal. Then coming back, you got your lateral malleoli. That again, the same, the distal. It's not distal posterior here, is it? It's just distal, or is it still distal posterior?
It's the posterior edge or right on the tip.
Yeah, I thought it was on the tip, because that's where it comes off and the
Mhm.
ligaments attach. And
Yep.
then inability to weight bear, is it like 2 steps, three
Mhm.
steps?
2 to 3 steps.
Yep.
Yeah.
Yep.
That's pretty obvious, that one, if someone can't weight bear.
Yep.
Yeah. Cool. There's another one that's probably important for not so much, actually, yeah, probably sporting population as well, but that would be the C-spine rules.
Oh, Canadian. Yeah, yeah.
Canadian C-spine rules. Do you know what
Yep.
the
So,
Canadian C-spine rules are?
yeah. So, in a build, oh, I said, yeah, maybe. But,
Here
like
we
if I
go.
get one of these, I always like go and quickly double check. If it's like if I get a traumatic post MVA and I'm their first point of contact and they haven't had an X-ray, I will quickly kind of check these up again to double check the rotation. But it's like
Hmm.
can't remember. It's like 45 degrees of rotation,
Yep.
either side.
Hmm.
Central tenderness, like to palpate. Hit greater than 60 kilometers per hour or 40 kilometers per hour. I can't remember which of the two. And so in a accident that unable to turn greater than that and central palpation. Oh, they're the only three that I can remember there.
Pretty good. So yeah, it is three. So the first one is dangerous mechanism, and a dangerous
Yep.
mechanism is a fall from greater than like
Fall from a height as well.
3 feet or
Yep.
5 stairs. Axial loading, so like if you've dived into like a sandbank or like you're diving and you cook it.
Yep.
Anything kind of over 100 k's an hour,
Oh,
definitely.
100 Ks.
Yeah,
Okay. I
anything
thought it was
there.
less. Cool.
Any motorized recreational vehicle. Yep. And a
So
bicycle
any
struck
car
collision.
accident.
Yep.
Yep.
And then the other one was, yeah, you already said 45 degrees left and right. Yeah, 45
Cool.
degrees. Cool. So that was those two. I think, yeah, you did pretty well. You're doing better than what you thought you would, I think. This
Yeah,
one,
yeah.
this next question has multi-part, and it
Oof.
is probably the most important part of today's podcast.
Oh, God.
What stuff can, what things can mess this up? What can stuff up bone healing?
Oh, what can stuff up bone healing? Oh,
Yeah, what
that's a
things can
really,
interfere or intervene completely with bone healing? There's quite a few, but
I would
I'll
go
keep a
like,
tally.
so, yeah, yeah, okay. So like certain medications and whatnot definitely can. So, depending on if
Specifics.
they're, yeah, well, we're going to have ones that like, um, so steroids because they help break stuff down rather than help it build up, especially kind of bony tissues because they leach calcium to enable your muscles to contract. Um, so you got that. You're going to have certain like immune mediated like things with cancer kind of treatments. So ones that kind of work on um, affecting your immune system, that type of stuff. What other medications are we going to go with there?
They're
Steroids,
probably the main
anti-immune
ones.
ones. Yeah, yeah.
I'll give you those two.
Cancer. Cool. Then like we're going to go with like kind of what I said before, like applying kind of tensile loads onto a bone kind of prior to it
Hmm.
creating that kind of callus formation because it's just going to continue kind of flapping around in the breeze.
Hmm.
It won't, depending on how close it will, it might not stop it from healing, but it might make the healing process a lot like harder and longer.
Hmm.
Um, so that would be like, I don't know, under the inappropriate mechanic transduction or whatever you want to kind of call that.
Yep.
Go nutrition kind of parts as well there. So like under nutrition
Hmm.
specifically.
Hmm.
And then if oh if you wanted to go like really like micronutrienty, I guess you'd go like calcium deficiencies and like protein deficiencies because they're kind of the building blocks of things.
Hmm.
But yeah, just under nutrition in general. So like I recommend people don't be in a massive, you're not trying to be losing weight at this time that you're trying to kind of heal your bone.
Hmm.
Um, Smoking would be one there because it's a systemic kind of thing that slows down. Basically, any kind of inflammatory chronic disease as well. So anything that kind of keeps, like, say, diabetes or chronic heart failure and
Hmm.
any of these types of conditions that are mediated by there being like a chronic inflammatory response that's kind of always occurring. I just say to people, it's just your body is just having to partition resources to so many different things that it's just going to slow down the amount of time that it has to be able to do it at that level, at that bone level. So we've got chronic diseases, we've done medications, we've done kind of inappropriate physical activity, we've done nutrition. I reckon that's pretty close to the list that I would be going for at the moment.
You've done pretty well. You've done, according to my list, you got 1, 2, 3, 4, 5.
Once I caught a fish alive.
Yep, 6, 7, 8, 9, 10. Steve didn't get the rest of the bone delay question. So inadequate blood supply. You kind of alluded to that with smoking and your chronic inflammatory conditions.
But you also have certain bones that do have poor blood supply too. Okay.
Also, some orifice nails, screws can be too tight and impede like intratrabecular like capillarization, that kind of thing. So there's less blood flow if you try and jam a nail in too tight or something like that. Infection. So we missed infection. Older age. People who are older have less ability.
Yeah, it slows.
Yeah.
Upper limb versus lower limb, I guess we could have gone as well.
Obesity affects hormone cascade responsible for healing of bones, as does menopause, parathyroid conditions. So those kind of endocrine type conditions as well. Yeah. Otherwise, you got the rest. Done pretty good. So
get the fin up.
Get the fin up. Next question. What things can we do to help it heal?
So, I guess the appropriate mechanotransduction would be my kind of first one. So, making sure that it's, you've got to make sure that it's like the union of it is close enough. So, that's where if you'll get an X-ray if you're worried about it being like traumatic enough that you think that there might be non-union, or that you'll just get an X-ray anyway. But if it's traumatic enough that they're worried about there being non-union, well, then making sure that you're bringing the end bits close enough together to actually heal is important. And then with that, the appropriate kind of loading to enable it to happen. So in that first little while, it's kind of no loading really, and then after that, it's just slowly increasing the appropriate amount of more initially compressive, and then you can start to get it to, as it's getting into that remodeling phase, you can get it to get used to the bending forces and everything that it needs to. Then after that, we're going to have an appropriate calorie kind of surplus versus deficit, and then the appropriate kind of micronutrient makeup of that.
Let's just assume the opposite of everything in the
opposite of everything else
in the other ones. The only other things to maybe mention, have you got anything other than what we've already mentioned?
No, get in the hyperbaric chamber, mate.
You kind of got close with the proximity thing. What would happen if the proximity was off?
You'll either just get like the too far of a distance to actually get that callus formation, or you'll get like a weird, like deformed kind of bone because it's like not lined up and whatnot.
Like your step in your clavicles is a classic
snowboarder.
But sometimes they don't like when this happens, so they'll use orifice. So we have surgery, bone grafts. Bone graft is another one. The other one, and I'm not so sure on this, but it was mentioned, I think this was maybe from Physiopedia, bone stimulation. So I've not heard much about bone stimulators, so I'm going to put this in the class out on this one. Just heard of it, not sure about it. You're not sure on it either?
Nope.
Cool. All right, let's take that with a pinch of salt as well. But yeah, I think we got pretty much everything there. The only thing maybe to mention about the excessive movement or the malalignment would be the amount of strain or the amount of stress that it takes to kind of stop fracture healing. That seems to be 2%. So
that's cool.
Yeah, it looks like anything kind of greater than 2% strain or anything, strain, because there's a difference between strain and stress, hey?
Hmm.
I can't remember my biomechanics for strain stress curves off the top of my head now. What's the
Yeah.
difference between stress and strain?
So strain is its ability to how much force it takes to deform it. Stress, no, hang on. Stress is how much form it takes, how much force it takes to deform it. Strain is the like rise over run curve of like how um where that exists on that
The
kind
the
of
rate,
XY. Yeah, yeah, yep.
the rate of bending.
Yeah, yeah, yeah. Yep.
Yeah. Okay. Cool. Well, Steve, I reckon you nailed the quiz. And that's all I've got.
Oof, there you go. How good's that? What do I win?
You win absolutely nothing. I've got
Nice.
nothing for you.
Oh,
Got nothing for you.
that's all right.
Hopefully we can win Nathaniel back onto a podcast with us soon. He's been off having fun playing daddy duties
Yeah, yeah. And playing golf.
and playing a lot of golf. Yeah. Do you reckon he's got a
Well, mate,
little
when you get back from the UK, we'll be able to bloody get the crew going a bit more.
yeah, for sure, for sure. I think we're still managing to get a few out, so I think
Nice.
in the next kind of month we should be able to do one a week. I think we've got one
Oh,
coming out with Blake from the Sports Medicine
nice.
Project.
Featuring Mia.
Yes, and that's on bone stress injuries. We've got one coming out on Reds as well, and then
Nice.
we'll have another bone loading scenario, seeing as that was a hit as
Perfect.
previously. So yeah, do you have anything to add for fractures or any other little tidbits?
Um, no, no. I think it's one that like um as I said before, I think the more common place for physio to be with it is that kind of the diagnostic stuff. So knowing your kind of your rules, your C spine, your Ottawa rules, your knee rules, and then kind of from there going, okay, cool, like how is this going to impact my management kind of thing,
Mhm.
which we've kind of covered there.
Yeah.
With the C spine, it's just like if you think a fracture, send it because that's not something that you're going to go, oh, we might just see if the body will do a little bit of,
Yeah,
you know,
let's mob that Dens fracture.
yeah, yeah,
Let's push
yeah,
that Dens right into the brainstem. Why not?
yeah, yeah, not ideal.
Good.
The other one
Um,
that actually like, so other one I think for me, and it's like the evidence I get, I think it's been more refuted recently, but I don't know, I still like to use it a little bit as like a clinical reasoning tool, just in Bayesian reasoning, putting lots of bits and pieces together.
mm,
And so I never use it on its own, but would be, and I've picked up a couple of traumatic lower back fractures, like
yeah.
spinous process fractures or whatever in the past with this. And that's the vibration, so sensitivity to vibration. So using the old tuning fork and
Hmm.
going, that and putting the tuning fork on the sore one. So you might palpate it. Yep, a little bit sore. Palpate up, and then but with the tuning fork, it like goes insanely kind of sore comparative to just like
Touch.
a yeah, yeah, and then compared to just like a facet joint arthropathy or something where it's just like, oh yeah, I just have a pissed off kind of joint.
Hmm.
Like, yeah. So that's one that I kind of tend to
You,
use if I'm wanting to just bring my likelihood suspicion of fracture up, and all it's doing is going, do I want to maybe send this person for an X-ray or not?
do you
But
actually
I
have
wouldn't.
tuning
That
forks?
was the only thing. Yeah, just one useful.
Wow. Yeah. No, I haven't been in a clinic with a tuning fork for ages.
Yeah, yeah. I used to when I was out on the sideline doing like sports coverage stuff as well, just seeing like, is someone just did have they just copped a big hit, or is it like, do I have to more say to the coach, no, just don't send this guy back out. I think he needs to go get an X-ray kind of thing.
Fair enough. Yeah. No, I'll have a look to see if there is any research that's been
There
refuted or
was, but
anything.
I think I think it is being like refuted as far as like it's only a little bit better than like a 50-50 kind of flip of the thing, whereas we
Right.
learnt it in uni as like
A
it's a
definite.
lot. Yeah, yeah, it was
It's
a really
sensitive.
good thing. Yeah, yeah.
Yeah, right.
Whereas
Okay.
it's really, yeah. There you go.
Yeah, a lot of what we learn at uni will probably has and will continue to change in the coming years. So
It's good.
yeah, progress happens.
That's right.
All right then.
Cool, mate.
Well, great little fracture crash course there. And for anyone listening, hopefully that was not super arduous, not an RPE 10 to get through fracture healing. Thanks for listening, and we'll see you next time.
Thanks, mate.